Good morning. I'm Dr. Devendra Gupta. I'm professor in anesthesiology, and I'm actually in charge of ICU of this COVID. So I'm going to present one case which is actually giving uh, the decision making information to the people who are actually managing the patients of COVID. So this is a male, which is a 50-year male. He was a resident of Lucknow and belongs to middle socio-economical status with a businessman. And date of admission was on 27th of August, and he was discharged on 13th of September. So in this 13 days of his uh, admission, actually the background is that he was hypertensive from last 25 years, and he was on telmisartan and metoprolol. And from last 1.5 years, he was found to be a diabetes mellitus. So he was on oral hypoglycemic drugs. So he was admitted on 27th of uh, 27th of September, August to our hospital, and he was referred from Medanta Hospital with a history of fever and breathlessness. He has also history of tobacco chewing and occasional alcoholism. So in the summary, as at the time of admission, he was a fever from last 7 days. It was continuous fever, high grade, dry cough from 5 days, and he was having a breathlessness, and he was found to be COVID positive. So once he was found to be COVID positive, he was admitted to Vedanta Hospital in Lucknow, and when he developed breathlessness, severe breathlessness, then he was referred to SGPGI ICU. So when we received this patient was low conscious, but he was very anxious. Blood pressure was a little bit higher range, 160 by 92. Heart rate was 98, and respiratory rate was around 26 to 30 in between. It was roughly 26 to 26. And at the time of receiving, the patient's saturation was 82 on room air, and when we put this patient on the oxygen, 8 liters, his saturation has increased to 96%. Then immediately we have connected this patient to the non-invasive ventilation that is called as BiPAP, and we have kept the BiPAP support of 16 and peak of 8, and we have kept the FiO2, that is oxygen which we are giving was 0.8. That means 80%. So at that particular time, the patient's little bit settled down. His saturation has increased to 96% and on a FiO2 of zero point 0.8. The preliminary investigation showed that there is a hemoglobin was 13, PSA was 74,000, platelet was 177,000, creatinine and LFT were seems to be normal. The ABG on this and IV support was the pH was 7.4, that is normal. PCO2 was in the normal range, 38.2. PO2 is 101, and which is, if we see the PF ratio is just between 100 to 150. The rest of electrolyte, bicarb, everything was normal. So the initial management which we have started was the one background antibiotic. Remdesivir we have started the bolus dose on the first day and followed by the 100 milligram OD for next 4 days. Dexamethasone as I described, because the patient was having a respiratory distress. The Clexane, which we low molecular parent, which we normally give. Azithromycin, telmisartan was his basic treatment for the hypertension. Vitamin C, Zincovit, Ascoril, as per the protocol of COVID patients. Insulin, because the patient was on oral hypoglycemic drug, so we have converted this to the insulin. Nebulization and on the Duolin and Gluticard has was on the delivery. But once we got the inflammatory marker and the X-ray chest, so X-ray chest, you can see the lower margin, you can see the upper lobe is a little bit clear, but on the lower lobe was having a haziness, both the side. Inflammatory marker shows that ferritin is more than 2000. CRP was also high. This is 225. Fibrinogen is also high, that is 630. LDH is 582, which is also high. FDP and DPT dimer were present. And we have, uh, but these markers were also maybe present, might be present in the state of infection. So just to rule out whether it is because of the COVID as per COVID pneumonia as per, or it is because of some sepsis induced. So we have to rule out by doing the procalcitonin. So procalcitonin was 0.2. That means there was no sepsis as such. So these inflammatory markers were raised because of the COVID infection. So if we have seen the CT scan, you can see the both the lungs from the middle. Upper lobe was clear, but from the middle onward, we can see on the both side, we can see the ground glass appearance on the whole of the lower, middle and lower on the body. So we were thinking of tocilizumab. So indication of tocilizumab in this patient, which is IL-6 inhibitor, was the adult patient's severe COVID pneumonia, increased inflammatory marker, and rapid clinical deterioration with a normal renal and hepatic. So we have given the first dose of tocilizumab 400 milligram immediately after when we have found that indication was there, and after 12 hours we have repeated this dose of 400 milligram again. So once the patient received the tocilizumab, his FiO2 started decreasing. The haziness, which was predominantly on the middle zone, has shown that there is a decrease in the ground glass appearance. You can see, you can compare with the previous X-rays, and there was the improvement in the ABG the level also on PF ratio X. So on the 5th day, patient BiPAP support we have stopped, and now the patient was able to maintain the oxygenation on the non-rebreathing mask 10 liters. Now once this BiPAP support was discontinued, so the patient can do the active proning also and deep breathing exercises. So on the deep breathing exercises, we can see that upper and middle zone has already cleared. There was some patches on the lower zone. ABG has also shown the good improvement. On the 7th day, the patient was on the 4-liter mask. You can see there is a dissolution of pneumonia on the both the side. Active proning, deep breathing exercises and other treatment was continued. And day 10, we can see this. The whole of the lower zone were also showed some improvement radiologically, and the patient has shown the clinical improvement as well. And the patient was doing the active proning, deep breathing exercises. So at the end, we can see that the TLC has not much increased, and one day there was one change in the increase in TLC, but once we have revised this, the repeater sample, that was 6.5. So, and you can see the inflammatory marker by the use of tocilizumab. There is a decreased trend of the inflammatory marker. CRP from 224 has decreased to 32. Ferritin, which was initially high to 2000, and it has decreased to 533. The fibrinogen level has all decreased. The procalcitonin remains same. So the only thing which we have to be monitored is that whether patient is developing sepsis. So once the IL-6 was given, the tocilizumab has been given, there is a high chances that patient may develop the systemic infection. So we have to monitor all the procalcitonin and all the parameter which was indicative of the sepsis. So we have to monitor clinically as well as by the blood values that sepsis component should not be there. If sepsis component is there, then we have to tackle it. So there is a high chances that patient may develop the sepsis, because we have given the immunosuppression to these patients. So we have discharged this patient on the day 15, and we have converted all the drugs on the oral medications. this methylprednisolone, which we were given by injectable dose, we have started with a tablet form, and we were given on the tapering dose. That means 60 milligram, which we have given on the for the first week. Then we have decreased to 20 milligram on the second week and 10 milligram OD for the third week. And rest of the medication we have advised as per this previous medications. So we can see that tocilizumab, the basic indication of COVID pneumonia is that IL-6 level is in 50 to 100 times increased than the normal. There is a worsening trend of inflammatory marker, that is ferritin, LDH, and CRP. There should be the deteriorating clinical condition with the worsening of the PF ratio, which should be more than 25% of deterioration from the immediately previous values. There are some contraindications, which is very important for before giving the tocilizumab, so that we can rule out all this contraindication. Then we have to start it. So the vigorous exercise need to be done to rule out all this contraindication, whether any condition of these should not be there in the patient before administration of the tocilizumab. So the major contraindication is that whether there is any active systemic infection, whether bacterial or fungal infection, should not be there in these patients. The procalcitonin, which is the marker of the sepsis, the high serum procalcitonin is the absolute contraindication in these patients. Active tuberculosis, active hepatitis, absolute neutrophil count is it's more than 2,000. Platelet count is, if it is less than 1 lakh. Neutrophil count is less than 2,000. It's contraindications. If there is a renal or hepatic impairment, then there is a relative contraindication in the patients. Patient on the chronic steroid therapy, pediatric patients less than 18 years of age, pregnancy and nursing mother are the related contraindication of the tocilizumab. So this is something about the one case which has shown that there is a good result of tocilizumab. But before I just concluded that first of all, we have to see whether this patient there is a absolute indication of tocilizumab in the particular patients. We have to select the patients accordingly, and before giving before administration the tocilizumab, we have to rule out all the contraindication, and there should be vigorous documentary exercises should be done before giving the tocilizumab. And after administration of tocilizumab, we have to monitor the patient clinically as well as the blood and other investigations, so that we have to catch any sepsis or because of this immunosuppression state, and we have to treat it accordingly. Thank you so much.